Hi, I'm Dr. Lori Stevick Rust. 40 years of sitting with people through their hardest moments has taught me one thing. Our power lives in our courage to be real. This is where we stop pretending and we find our way back to ourselves. I'm glad you're here. Now pull up a chair. This is Becoming Real. The advice on prostate cancer screening has swung back and forth over the years. Don't test, do test, when to test, or simply just go talk to your own individual doctor. And honestly, that back and forth of seemingly contradictory guidance can lead a lot of men to simply do nothing. So while we wait for clear answers on testing, advanced prostate cancer is climbing in every age group, including men under the age of 55. And the guidelines your doctor actually goes by, the U.S. Preventative Service Task Force and the American Urological Association, haven't had any meaningful changes in their recommendations since 2018. In fact, the task force, the body that sets the guidelines and shapes what your insurance will cover, hasn't even met in over a year since Secretary Kennedy fired its leaders. So where does that leave men? Consider this. Even the most medically protected man in the country wasn't safe. Jill Biden's memoir opens with her family's shock. Former President Biden diagnosed with stage 4 prostate cancer. And how does that happen? Because those same guidelines agree. Both the task force and the Urological Association say men over 70 generally don't need routine PSA screening. So President Biden's doctor stopped testing. He hadn't had a PSA check since he was 72, according to the reports. If it can slip past that much monitoring, that much medical scrutiny, the rest of us can't afford to wait. We have to know how to advocate for ourselves and for our loved ones. Because I watched it happen with my husband, Jay. You just heard his story in the episode prior. His doctor hesitated on getting his PSA because 3 years earlier, Jay's numbers were normal. Jay had to push. He asked for the test anyways. By the time we found it, the cancer was already at stage 3, outside the prostate. And Jay had no symptoms, none. A normal test 3 years before, no warning signs, and it had already spread. That push of his doctor to get his PSA saved his life. And here's what we've learned throughout this. Not all prostate cancer is the same. Some sits quiet and can be watched for years. Some types spread so fast. And a PSA number, a Gleason score, family history, your age, your race, they all change the picture. So let's get the facts from an expert. Let's ask those questions that every man and every family deserves to have answered. I'm so pleased to introduce Tyler Weisent, nurse practitioner, who along with Dr. Gia were our lifelines through Jay's cancer journey. Tyler is an American Oncology certified nurse practitioner at University Hospital's Seidman Cancer Center, right here in Cleveland, Ohio. And he specializes in radiation oncology. Tyler's primary focus is providing care for patients with genitourinary cancers, specifically in the setting of newly diagnosed prostate cancer, biochemically recurrent prostate cancer, metastatic prostate cancer, bladder and renal cancer, as well as palliative services and treatments. He's also part of the clinical trial team as a private investigator, helping to develop new treatment options, new methods for advanced settings of prostate cancer. He's a local resident here in Cleveland, Ohio, and has lived here for the past 10 years. He obtained his bachelor's degree from Kent State University and his master's from the University of Cincinnati. So let's just jump right into this conversation and get some answers. Okay, Tyler, I am so excited to have you here today because we have a lot of questions, and I'm hoping you're going to have some good answers for us. So first of all, thank you again for taking time. I know it's a busy clinic day and spending a little time with the listeners today to help us get a little bit more educated.
Yeah, definitely. I'm always happy to kind of get the word out.
I know you heard me say before that as a non-expert in prostate cancer, although now I feel like I'm quite educated because we had to be with our journey with Jay. I was shocked to find out that really the guidelines that are still talking about you just don't do standard testing, PSA testing for men over the age of 70 unless there's some indicator. And that alarmed me for a couple of reasons. One is Jay had no symptoms. So if we were going by just an age or like he doesn't have other high risk factors, although he does have a family history, there probably would not have been testing had he not nudged his primary care doc a little bit, who was sort of saying, well, the guidelines are telling us this. And so we probably could wait a little bit longer, or we don't need to do those routine screenings. Can you speak to what feels like contradictory guidelines? What are men supposed to do? And specifically when there's no symptoms?
In regards to prostate cancer, the large majority of men, unfortunately, that are diagnosed are really asymptomatic to begin with. So I always tell guys, just because you feel good doesn't mean everything's going great for you. And really, you should, if somebody's recommending you have these checked, you should have it done, especially if you're within that guideline window. But I kind of like to note with guys, and just like you mentioned with Jay's history, it's a personalized approach. So the screening, as you know, they're called guidelines for a reason. It's not the end all be all. And that's why it's important to have that discussion, especially for men that are very healthy. They have another 10, 20 years ahead of them. They certainly should be getting screened. And really the reason for that is, most prostate cancers in and of themselves, they are slow growing, but given 10, 15 years to propagate, they will become a problem for you. So screening really 50 to 70 is great, but I tell guys if you're 71, I don't see a reason to stop if you plan on being around till 90. And that even reflects upon the younger men as well. A lot of people, the myth out there is that prostate cancer is an older guy's game, and that holds true to most beliefs that large majority of men are diagnosed in their 60s, early 70s. But there's subsets of men that are in their 50s and late 40s that are diagnosed as well. So just like with Chase, understanding what are your risks? Do you have a family history? Those kind of things when you should be getting screened. It may be sooner. Maybe you should continue to go, So I think it's really important you have a discussion with your primary care or your urologist, whomever you see, and really have them break it down to you so you can find out, is it something I should be doing now? Or is it something that, I can wait a few years?
Yeah, yeah. Are you seeing, is the data showing us that more aggressive prostate cancer is on the rise with younger men?
So it's difficult that, I would say if I had a tracker and I was in clinic, there's certainly, I see more aggressive forms of prostate cancer, but I think that that is more maybe dependent upon facility based on where you're at, and what trials are available. Obviously, men with more advanced disease, if you're offering more advanced trials for disease and things like that, you're going to see more of those men in clinic than you typically would. Looking at the demographic information that's out there, it does seem like there's more advanced prostate cancer or men that are at least, presenting with more metastatic disease than there has been in the past and at younger ages. And that kind of holds true for all cancers across the board. Cancer's on the rise. Just recently, it's surpassed the main cause of death in the United States. And at the end of the day, 1 in 2 people will have cancer in their lifetime, not prostate cancer, but cancer as a whole. So it's something that's certainly on the rise. A lot of folks will ask me, what's the smoking gun behind all these rises? And there's not necessarily a cut and dry answer to that. It's a combination of things, lifestyle factors, what we're exposed to, all of those things. There's unique cancers like lung cancer, obviously. If you're a heavy smoker, we can say, yeah, that's more than likely the cause. But for most cases, they're sporadic in nature.
Yeah. That's interesting, obviously, as a psychologist, and because Jay's been very honest in sharing his story. I've had several people, young men, I call them young because they're like in their late 40s, that I've started to see because they were diagnosed with prostate cancer, which again, thinking this is an old man's disease, not a 40-some-year-old man's struggle. And so, of course, you can imagine psychologically there's a lot around that. So I don't know if it's just because we're spreading the word, getting men to pay more attention, that I'm starting to see a little bit more of that, because I think prior to this, if you had asked me, I would have thought, yep, here's what I know about prostate cancer. It happens to older guys. I would have probably said 70s, 80s, and it's slow growing. And, It's not a big deal, and you'll probably die with it as opposed to whatever that saying is, you'll probably die
Die with
with
it, not
it as
from it.
opposed to from it. Yeah.
Yeah.
Um, and to be honest, that was one of the things that Jay and I were talking about in our interview, the last episode, was probably one of the most frustrating, maybe, experience for us was that people would say, "Oh, you got prostate cancer. You got the good kind then. Of all the cancers, that's a pretty good one for you to have." Because they're thinking about, "Oh, we're gonna watch this and monitor this all the way in through the end of your life." And that, of course, was not our journey. So I think it's important for people to understand, and hopefully after our conversation here and we really break this down, that there's a lot of variation in what prostate cancer looks like. So, but before we get into that, maybe we ought to start with the basics. What is the prostate gland? What does it do? And then talk a little bit about prostate cancer.
Yeah, yeah. So, I mean, the prostate itself, it's a gland located right beneath the bladder. You may hear a lot of times it's about the size of a walnut, somewhere around like 25 grams, if you know how much that weight is. It has a lot of function for men, specifically on that sexual side of things. So, produces a lot of the fluids that are needed for, sperm nutrition. It's also really important in hormonal actual regulation. So, it might be small, but it has a lot of mighty power when it comes to guys' sexual function and urinary function in of itself because the urethra. So the tube that we urinate out of passes right through it. So when there's problems there, guys are going to have problems peeing as well. So definitely very important organ in there. How prostate cancer truly happens is, as with any cancer, it's a mutation. Why that mutation happens, again, just like I mentioned before, it's hard to pinpoint an exact cause. There's certainly people that are at higher risk, people that have familial genetic mutations, things like BRCA1 or 2 mutations, things like that, where you see kind of these trends in their families of prostate or breast cancer, and they end up getting genetic testing and finding out. It'll definitely enhance your risk. But 1 in 8 guys at the end of the day are going to get prostate cancer. The exact cause sometimes is just sporadic, just happened. And yeah, most prostate cancers are slow growing. It takes years for it to develop and years for it to sometimes become a problem for men. Kind of screening and picking up on those things, the first thing you can do is get a PSA. Like we kind of talked about, the sooner you're getting those PSAs, the sooner we can start a workup if we find something abnormal. PSAs are the protein that is really given off by the cells in the prostate itself. It's floating around in our bloodstream, so it's a very easy screening tool. There's no imaging. You hear a lot of times about digital rectal exams. There's a lot of stigma around that. When men think prostate cancer exams, it's really kind of become something of the wayside, to be honest. We have MRIs, which are extremely detailed nowadays. We have, these beautiful PSAs that are even more and more accurate. So we can really kind of fine tune things a little bit more. So I always try to tell men too, this big stigma about getting in there and being tested. I tell them it's simple 2-second blood draw could save your life, But yeah, the PSA is how we follow things. I always tell guys, just because your PSA comes back high doesn't mean you necessarily have prostate cancer. So it again goes back to just with the screening, having that discussion with your provider to kind of figure out, is this something I should be doing? And when you get the results, how does this fit the picture for me? And what I tell men is you can have elevated PSAs for a multitude of reasons. You could have urinary tract infections that will raise your PSA. You could have been sexually active that'll raise your PSA. You could have a condition called benign prostatic hyperplasia. Big fancy word for your prostate's just got a bunch of benign tissue and is growing as we get older, which happens in all men. Once we get over 50, it just keeps getting a little bit bigger. And because of that, it'll just slowly push your PSA up a little bit, maybe right outside that normal range. So really, you have to look at it in context to the individual when we're talking about PSAs and in regards to the prostate itself.
Okay. Well, that was going to be my question. I think you answered it because, this is that comparison thing. And once men start talking about it, it's, well, my PSA was only this number and yours was this number. And, then it becomes that comparison of like, can you have cancer and have a low PSA reading? And I think you kind of got to that answer.
Yeah, and I tell men, the normal range of PSA, I call it out in the wild, if you will, before you've been diagnosed, things like that, 2 to 4. There's certainly men that have low producing PSAs that are that still have prostate cancer. And that's why it's a screening tool. It's not perfect. And that's why we have to take it in context of the individual. For example, somebody that has a PSA of 1.8 for years on end, and then they come in and suddenly their PSA is 3.8. Hey, it's not outside the range, but it's doubled. That's abnormal. And if you're seeing a urologist or primary care, they're going to look at that and say, yeah, you are in the normal range, but this is double. This is abnormal. So even though you're still in that normal range, you should still get checked. You should still have this worked up. And that's why it goes back to really looking at the context and making sure there's nothing else going on in the background, looking at your PSAs and how they've trended in the past as well, to really determine the next step, which is really that workup part of it, where we're going to say, all right, maybe there is something going on here. Let's step this up and get an MRI, some detailed soft tissue imaging of your prostate, see if we can see anything in there. And if we do, let's stick a needle in there and take a sample of it.
So that really is the next step then, is if you're really trying to identify could there possibly be cancer, is a biopsy.
Correct. So the next step would typically be your PSA, and say it came back elevated and it was 8. Okay. I would typically recommend you get an MRI and then get a biopsy of that. You know, the biopsy will tell us a little bit more. We have a nice scoring system called the Gleason system. Lots of guys, if you're out there Googling it, you'll see all kinds of stuff, but it's a nice addition problem, if you will. And really all it's saying is we took this tissue, we put it under a slide, and we assigned it a number between 3 and 5. And there's always 2 types of cells. There's either 3, 4, or 5. And it's an addition problem. So if there's more abnormal 3 cells than there's abnormal 4 cells, we say it's 3 plus 4 equals 7. And if there's an equal amount of abnormal 4 and 4 cells, we say it's 4 plus 4 equals 8. The higher that Gleason score is, it tells us that there's a large abnormal amount of cells. So the higher that number goes, it's just saying those cells are very abnormal. The more abnormal things are, the more likely it is to be a little bit more maybe biologically aggressive, which raises concern and also what we call upstages you. So part of getting everybody staged is getting that PSA, get that MRI, get the biopsy and Gleason score. And if your Gleason score is high enough, maybe we need to get a PET scan and check your whole body to make sure, hey, this is pretty abnormal. There could be something that was already out of the bag, if you will, and we need to make sure we're catching it. And that kind of complete a staging workup. To kind of get you dumped into what I say in a nice way, buckets. Those buckets are really what kind of tell us how we should be treating guys. So you may hear with a lot of cancers, there's stages. Oh, I have stage 1 cancer. I have stage 4. I have stage 3. Prostate cancer, we'll give you those stages, but we have a little more unique system that we like to call, and I kind of like to say it's a speedometer, where you have low risk, you have intermediate risk, you have high risk, and then you have what's called metastatic, which is disease outside the prostate. It's a speedometer, meaning that the low risk guys, they're going like 10 miles an hour on a highway where it's 60. I'm not worried about them. We just keep an eye on it. The guys that are starting to get in that intermediate range, we're starting to say, hey, we should do something here, whether it's radiation, surgery. Kind of having that discussion is really important with, both your urologist and your radiation oncologist. And then really start to get into high risk. And those are the guys that we should definitely be doing something, whether it's radiation, hormonal therapy, it's surgery. And again, it's the same concept. You need to see both of your urologists to talk about surgery, but also you need to see your radiologist or your radiation oncologist to kind of talk about what should we be doing from a radiation perspective and what those side effects would look like as well. So what I tell guys, you're going to fall into one of those buckets. If you have metastatic disease, there's still available options with radiation and hormonal therapy, but it's certainly a more advanced setting where we need to incorporate medical oncology as well to really discuss, should we be adding not just hormonal therapy, but something to that hormonal therapy that's a little more cell killing, if you will.
It's a lot, I know, when somebody's diagnosed, to start to figure out how to make those choices. And again, I've had conversations with men now far more than prior to Jay's diagnosis, of trying to decide, well, I don't want this, like I don't want surgery because I don't want this side effect, or I don't want to have this complication, or radiation I've heard is X, Y, and Z. Like for us, there was no other option other than surgery. If there's cancer in there, it's got to come out. And we were kind of in that, given a lot of different options. Like, do we start with radiation? Do we start with this? I know this is an individualized question, but I always feel like it's important that, particularly for men who are already struggling with what this is going to mean for their life, they're going forward, the aftercare, all of that, to not make decisions based on fears that might not be accurate, so
Yeah.
that thought process. So can you speak to some of that, like options, and based on what you've just said? It all depends on the process and where the person's at, but making sure that we clear up any misunderstandings or myths that you've heard from men when they say, oh, I don't want surgery, for example, like I got to hang on to that prostate, or I don't want radiation because I heard that sexual function is damaged from that, or whatever those myths are that you keep hearing from people. Let's set the record
Yeah.
straight.
Yeah, that's a good question. So, just like you mentioned, anybody's going to come in with their pre-notions as to, what they think could or could not happen. And I tell a lot of folks that come in, that decision, it's a shared decision that needs to happen. And really to make that shared decision, you have to have a full understanding of both what radiation would look like as well as surgery. So that's why, if you notice when I mentioned the treatment for these guys when they're in buckets and, you have options between surgery and radiation, you need to see both teams, both the radiation oncologist and the urologist, the surgical team, because at the end of the day, my forte, I'm not in this OR. I'm not operating on these men. So I would rather, just like if you took your car to a mechanic, you're not going to go ask the auto body guy to do the checks on your engine because he doesn't do that on a routine basis. There's definitely skill set to it, and the surgeon can speak more to that. And just like the radiation oncologist can speak more to the radiation perspective. I do find that men, when they come in, they've sometimes already had their mind made up.
Mhm.
And I totally understand that. I'm not there to kind of persuade them and be a car salesman. A lot of times folks will have done their own research, whether it's Googling, they've read articles, they're very well informed maybe on the research out there, or they have family members, they have a brother, they have an uncle or cousin that's had surgery and did really well. And they're like, you know what, I just want surgery. He did great. I think I'm going to do fine. Or they had somebody that did great with radiation or, vice versa. And they'll already kind of have a pre-notion. I also have folks where it's a mental factor. I need this physically out of me. And if that's the kind of person you are, I typically tell folks, I will tell you all about radiation. But at the end of the day, if you feel like you need to have this out of you, then that's a treatment decision that you need to make. But in regards to things that I hear a lot of times, radiation over the last 10, 20 years has changed so much. And I'll have patients come in and they say, oh, my uncle got radiation in 1990 and he had all of these terrible rectal side effects and all of these terrible urinary things. And I tell men, radiation has changed a lot and the toxicity, both the urinary, bowel, and sexual function has vastly reduced. But as with any form of a procedure, there's going to be some risks. And we know what those risks are. For the large majority of men, you're going to have some urinary urgency frequency while you're on treatment. You may have a little bit of diarrhea while you're on treatment. It's just like if you had surgery, you're going to have a couple aches and pains for a few weeks. You're going to have some of these symptoms for a few weeks. There's certainly a little bit of sexual function that can develop. About 30% of guys over a 2-year, 3-year time span after treatment will notice some decline in their sexual function. So I tell guys, like, it's really important to understand what your concerns are when you come into that office. Am I primarily concerned about my sexual function, how I'm going to perform afterwards? Am I more concerned about urinary incontinence, things like that? Because certainly each form has its own side effects that are slightly higher. With surgery, you may have some increased risk of incontinence and sexual dysfunction where that's reduced typically in your radiation population. But if somebody has a mental mindset of I need to have this out, then they're maybe accepting to those risks. So it's about really, I usually tell guys coming in and making a line, when you hear that list where you make it where it's like, oh, these are the positives, these are the negatives. You need to find out what are your positives and what's acceptable to you for each patient. So really what I tell guys, you need to come in and focus in on what are the urinary, what are the bowel, and what are the sexual side effects, both in the short term and the long term, and what is acceptable to you. And that's for both radiation or a surgical approach.
Mhm. Yeah, and I think, thank you for that, because I think there is a lot of, certainly sexual function is a big issue, and leakage is a big issue. I sometimes laugh and say, welcome to the postmenopause for women. You cough and you're peeing yourself. So, these are these are the things that can happen in general as we age. But I know that the sexual function is probably one of the biggest things that you probably hear a lot of. The prostate has to come out, and Jay talked about that. Like, you lose that whole sense of now there's no semen. Like, just psychologically, there's a whole thing about that. Can you speak to the kinds of things between the prostate being removed, radiation, and then even you mentioned the hormone therapy treatments, what role testosterone plays, and talk a little bit about that, about what men who are going through this could expect, and then what comes after, like what's life after look like?
Yeah. So yeah, when you're on treatment for, your prostate cancer, if you're choosing the radiation course, and say you fall into one of those buckets where we say, hey, we should add maybe a short course or long course of hormonal therapy. Hormonal therapy, the whole goal is to lower your testosterone. It feeds the androgen receptors on the cells, the prostate, and it tells those prostate cancer cells to grow. So when we give hormonal therapy, it's not that we're giving you testosterone, we're actually giving you medications to take testosterone away. So what I tell guys, it's kind of like having menopausal symptoms. It's certainly a spectrum. A large majority of guys kind of fall in the middle. They're going to have a little bit of everything I mentioned here. And then there's guys that are, outliers. There's men that have none of those symptoms. There's guys that have it a little bit more to the more extreme side of things. Large majority of guys, though, going to have some mild hot flashes here and there, like maybe 2 to 3 hot flashes a day. You're certainly going to have sexual dysfunction. Doesn't typically impact you when you're on hormonal therapy. It usually impacts their partner. Testosterone's a big libido driver. So I tell guys, you're just not going to want to, have sex, which men are blown away by that, and I tell them,
Hmm.
I promise when you start this, you're not going to care. You can certainly have, some muscle wasting because testosterone's important in muscle development and even some mild weight gain. So what I tell guys, when you're on therapy, stay physically active. I'm not telling men to be Olympic athletes by any means. I'm like, get outside and walk 20 minutes, 4 or 5 times a day. Things that kind of stimulate your muscles. It keeps the muscle around, keeps the weight off. It really helps with the other symptoms too, with the hot flashes and even some of the mood swings that may happen. But for the large majority of men, it's just that, a little bit of everything. When they come off of therapy, testosterone comes back, those things go away, sexual function returns. You're back to baseline. It's not an on and off switch. Like, testosterone takes some time to come back, but realistically, those things will come back. From the perspective of radiation, when you do have your prostate radiated, you will lose some ejaculate as well, and it may go away altogether as well. So I always try to inform men of that, especially younger guys, late 40s, early 50s. They may still want to have children. So I do always make sure to highlight that at consult, especially with my younger guys. From the surgical perspective, when they cut the prostate out, you'll definitely have dry orgasms. The risk of sexual dysfunction is a lot higher. Radiation, about 30% of guys can have a decline afterwards. It's usually not impotence. It's like a little harder to get an erection, those kind of things to initiate, if you will. Surgery, it can fall into like the 70% or more of men that have sexual dysfunction that's significant enough that like medications will not resolve. Unfortunately, the nerves that are involved in sexual function wrap around the prostate. Surgeons are going to do their best to avoid cutting those nerves. But at the end of the day, if the disease is involved into those nerves, they will need to do something about that. The whole point of cutting that gland out is to get the cancer out.
Right,
Uh,
right. Yeah. And it's not for all men who have surgery. I know for Jay, they were careful and able to preserve those nerves. So
mhm.
it's again not thinking, gosh, if I have surgery, I'll never have an erection. I could never have sex again. That I think everything you're saying, because that's been our experience too. That was not Jay's experience, even though he
Mhm.
had surgery. Um, and and I'm glad we're talking about this openly because it becomes then, wait, I heard my friend who had surgery and then he could never get an erection again. Like,
Yeah.
making sure that everything you're talking about is driving home the point. This is a very individualized experience. And while there might be, generally speaking, this is what happens, I like your concept of there are buckets and then there is a range within those buckets. So,
Yeah, definitely. And yeah, going back to like the prostatectomy, the actual surgical removal of the prostate, there is nerve sparing. And nerve sparing is very popular for those reasons, maintaining sexual function. And just like I said, there's a spectrum. So they're going to tell you, we're going to do nerve sparing. They may get in there and say, we can't do nerve sparing. And it's just like with radiation. The anatomy is different for everybody. We're going to do our best to avoid the area called the penile bulb where those nerves are at. But if your prostate's pushing right up against that, we need to treat that area and we will try to spare as much as we can. But I tell men to be cognizant of that if that is something that they're super concerned about. So again, understanding the concerns when you come in, if sexual function's a big topic of discussion, which I have men that come in and that's what they want to preserve the most. And that's what they care about the most. And we really highlight that with them for both sides.
Yeah. Well, that's why I think I've said in the opening here, between you and Dr. Gia, you guys really were our lifeline because it's a very scary and overwhelming. Because, of course, the ultimate goal is just to keep your loved one alive, and you'll take whatever comes with that. But you guys were very, very, uh, educating us, keeping us grounded, that we didn't get 5 steps ahead of ourselves, and yet we knew what the path looked like. Like, I needed to know if this returns again, what does that look like? Because that is how my brain copes. So I think my takeaway from all of this has certainly been you have to find your right partner in your healthcare providers so that you're safe to talk about these things, that you don't have to feel like you're blown off and I know that there are some people saying, I'm not getting that collaborative feeling. And then I just say, you go find those people. You got to find your right team. And I will just take this public opportunity to say we found our right team and you guys were truly our lifelines through all of this.
Yeah.
So
Yeah, yeah, and it is. It's a collaborative experience. You really have to, not everybody meshes, unfortunately. There's
right.
certainly people that may walk in and say, I don't even say hi to them, and they're like, I don't know what it is, don't like you. And I'm not going to argue with them. Hey, I'm the same way. If I see somebody and I don't have a rhyme or reason as to why, my job is to just instill as much knowledge and confidence that I can in you while you're here. And if that changes along the way, great.
Yeah.
But my main concern is that you understand what's going on.
Yeah. So in closing and getting, kind of wrapped here, let me ask you, I know that you're involved in research also, and you're certainly in the arena of metastatic disease. So um, give us some hope. What's out on the horizon? What are you seeing in terms of new things to get excited about, whether it's about detection, prevention, treatment, life-saving, longevity kinds of research? Just tell us something we can be hopeful about, Tyler.
Yeah, yeah. So there's tons and tons of stuff out there. I always like to tote. We have a nice trial ongoing right now. It's called Starlight, and it is for men that have very high risk prostate cancer that's even spread maybe to a lymph node. Now we're in this trial. We assign you to radiation with a medication called Pluvicto, which is very, very expensive that you get for free. And it's not hormonal therapy, so you forego the hormonal therapy and you just get the radiation and Pluvicto. So it's something that isn't, again, incorporating intensive therapies more upfront for men, hopefully having better outcomes, reducing hormonal therapy. Certainly, I mean, Decipher testing now is out there in the world everywhere. We just finished recruitment for a very large trial using Decipher testing. So next few years, we should be getting the data back about that. And it's kind of helping us guide again on using hormonal therapy in certain men and maybe stepping it up, maybe actually getting rid of it, those kind of things. So our research here tends to be more focused on those advanced disease settings and trying to reduce hormonal therapy or intensify therapy early on. Yeah, there's a lot. We don't have too many new screening trials here, but I know there's many out there, which is great to see. We're always trying to get more and more trials here. Just A, gets more patients in, but B, we're just learning a lot more about prostate cancer. Genetics are definitely where things are headed across the board for all cancers. So I'm sure you'll see more trials in the future about that. There's CAR T cell therapy for extremely, extremely advanced populations of prostate cancer. There's a trial ongoing in our medical oncology department with that. The future seems, really good for men. So
I love that answer. I love that conclusion of, especially around the prevention and the screening, as I started at the top of the episode here today and of the show talking about. My hope is that there'll be less confusion around screening, more up-to-date guidelines, that we start getting the word out there. I know that they are just guidelines, but I think there are certain physicians that follow those guidelines. There are people who hear those guidelines and they incorporate it like, well, I'm over 70, I don't need to be tested. So I just hope that we, at the front end of this, to prevent men from having to go through all of this, that we continue to keep ourselves from the research perspective and the task force that is responsible for putting these guidelines out, that they stay on top of this as well. That's my personal private hope. So all right, so it is now Men's Health Month, as we know. So, in all that you see, all that you've experienced, is there some parting word you want to give out there to men about taking good care of themselves, about their prostate health, about screenings, or anything that we didn't cover today?
Yeah, I mean, if there's one takeaway, I tell guys, get in. Don't worry about the stigma about being tested. You need to get in there, talk with your primary care, talk with your urologist, have the PSA drawn. That's the first step to getting yourself screened and making sure there's nothing going on. That's really going to kick the ball off and it could save your life. I've got guys that come in and they're like, man, I so happy I went in and had this done. I'm so grateful for the team here. And now there's nothing going on. I can live my life. And that's the one main takeaway if I give it to guys. Get tested.
Good, good. I love it. And I so appreciate your time with us today, Tyler. You've answered a whole bunch of what I know are big questions for listeners out there. So thanks again for your time.
No problem, Lori. You have a good one.
Thank you for spending your time with us today. Before you go, if this episode touched something real in you, please consider sharing it with someone who may need that too. If you'd like to stay connected beyond the podcast, sign up for my email list at drloristevick.com. That's where I share more reflections, resources, and an invitation to join the real conversation, which is my free live monthly gathering for women who want deeper conversations beyond the podcast. Until next time, be brave enough to be real.